Erectile dysfunction affects up to 71% of men during their lifetime, with prevalence rising from 5% at age 40 to 15% at age 70. It's not just a quality of life issue. Indeed, it's often an early marker of systemic diseases such as diabetes and cardiovascular disease. Diagnosis still relies mainly on clinical history and validated questionnaires such as the IIEF-5. Imaging tests like the penile Doppler ultrasound or MRI remain limited by low diagnostic accuracy. First-line therapy remains phosphodiesterase type 5 inhibitors, which are effective in most men and linked to a 19% reduction in cardiovascular events and 44% lower mortality in long-term tadalafil users. However, dropout rates can reach up to 76%, often due to cost, side effects, or lack of efficacy. For non-responders, intracavernous injections of alprostadil succeed in up to 93% of cases. Emerging options like botulinum toxin A show short-term improvement in over 50% of patients. However, this still remains experimental. Regarding regenerative therapies, low-intensity shockwave therapy shows modest improvement, about 3 points improvement in the IIF, however does carry an excellent safety profile. Platelet-rich plasma yields improvement in up to 70% of patients at 6 months, however evidence remains inconsistent. Stem cell therapy remains experimental, with fewer than 400 patients studied worldwide. Regarding new frontiers, future treatments may target Rho kinase, guanylyl cyclase activators, or use radiofrequency devices which improved IIEF scores by over 40% in early trials. However, until robust data emerge, ED treatment should be tailored, addressing underlying systemic risk factors and combining evidence-based pharmacologic and behavioral approaches. To conclude, ED remains a multifactorial condition, and while PDE5 inhibitors are still the cornerstone, regenerative and neuromodulatory therapies are expanding possibilities, however require standardized protocols and high-quality trials before routine use.